Myocardial infarction. Myocardial infarction (MI) refers to a dynamic process by which one or more regions of the heart muscle experience a severe and prolonged decrease in oxygen supply because of insufficient coronary blood flow. Subsequently, necrosis or death to the myocardial tissue occurs. The onset of myocardial infarction process may be sudden or gradual, and the progression of the event to completion takes approximately 3 to 6 hours. Pathophysiology and etiology. Acute coronary thrombosis, partial or total, associated with 90% of MIs. Severe coronary artery disease, greater than 70%, narrowing of the artery precipitates thrombus formation. Intramural hemorrhage into atheromatous plaques cause the lesion to enlarge and occlude the vessel. Dissecting hemorrhage can also occur. The plaque ruptures into the vessel lumen and a thrombus forms on top of the ulcerated lesion with resultant vessel occlusion. Other etiologic factors include coronary artery spasm, coronary artery embolism, infectious diseases causing arterial inflammation, hypoxia, anemia, and severe exertion or stress on the heart in the presence of significant coronary artery disease. Example, surgical procedures or shoveling snow. Different degrees of damage can occur to the heart muscle. Zone of necrosis. Death of the heart muscle caused by extensive and complete oxygen deprivation, irreversible damage. Zone of injury. Region of the heart muscle surrounding the area of necrosis, inflamed and injured, but still viable if adequate oxygenation can be restored. Zone of ischemia. Region of the heart muscle surrounding the area of injury which is ischemic and viable, not endangered unless extension of the infarction occurs. According to the layers of the heart muscle involved, MI can be classified as transmural Q-wave infarction. Area of necrosis occurs throughout the entire thickness of the heart muscle. Subendocardial infarction, also called non-transmural non-Q. Area of necrosis is confined to the innermost layer of the heart lining and the chambers. Transmural Q-wave infarction, subendocardial non-transmural non-Q infarction. Location of MI is identified as the location of damaged heart muscle within the left ventricle, inferior, anterior, lateral and posterior or right ventricle. Left ventricle is the most common and dangerous location for an MI because it is the main pumping chamber of the heart. Right ventricle infarctions commonly occur in conjunction with the damage to the inferior or posterior wall of the left ventricle. Region of the heart muscle that becomes damaged determined by the coronary artery that becomes obstructed. The amount of heart muscle damage and the location of MI determine prognosis. Patients with endocardial infarctions should be considered as having an uncompleted MI. Monitor carefully for signs and symptoms of extension of heart muscle damage. Clinical manifestations: chest pain, severe diffuse steady substernal pain of a crushing or squeezing nature, not relieved by rest or sublingual vasodilator therapy but requires narcotics. May radiate to the arms, commonly the left, shoulders, neck, back and or jaw. Continuous for more than 15 minutes. May produce anxiety and fear resulting in an increase in heart rate, blood pressure and respiratory rate. Diaphoresis, cool, clammy skin, facial pallor. Hypertension or hypotension, bradycardia or tachycardia. Premature ventricular or atrial beats, palpitations, severe anxiety, dyspnea, disorientation, confusion, restlessness, fainting, marked weakness, nausea, vomiting, hiccups. Atypical symptoms: epigastric or abdominal distress, dull aching or tingling sensations, shortness of breath, extreme fatigue. Many patients do not have symptoms. These are silent myocardial infarctions. Nevertheless, there still is resultant damage to the heart. Women often present with atypical or vague complaints. Example: epigastric pain, gas feeling, or tired. Elderly patients are more likely to experience silent MIs or have atypical symptoms: hypotension, low body temperature, vague complaints of discomfort, mild perspiration, stroke like symptoms, dizziness, change in sensorium. Diagnostic evaluation: ECG changes generally occur within 2 to 12 hours but may take 72 to 96 hours. Necrotic, injured, and ischemic tissue alters ventricular depolarization and repolarization. ST segment depression and T wave inversion indicate a pattern of ischemia. ST elevation indicates an injury pattern. Q waves indicate tissue necrosis and are permanent. A pathologic Q wave is one that is greater than 3 mm in depth or greater than one-third the height of the R wave. A normal ECG does not rule out the possibility of infarction, and ECG changes can be subtle and obscured by underlying conditions: bundle branch blocks, electrolyte disturbances. Elevation of serum enzymes and isoenzymes. Enzymes are drawn in the serial pattern, usually on admission and every 6 to 24 hours, until 3 samples are obtained. Enzyme activity then is correlated to the extent of heart muscle damage. Enzymes commonly evaluated include creatinine kinase (CK), lactic dehydrogenase (LDH), and aspartate aminotransferase (AST). CK and LDH can be broken down further into isoenzymes which are more organ specific. CKMB is specific to heart muscle and thus the most sensitive enzyme for determining heart muscle damage. LDH1 and LDH2 are specific to heart muscle and thus elevated. Other findings: elevated cardiac troponins, elevated elevated myoglobins, white blood cell count and sedimentation rate elevate due to inflammatory process associated with the damaged heart muscle. Radionuclide imaging allows recognition of areas of decreased perfusion. PET, positron emittent scan, determines the presence of reversible heart muscle injury and irreversible or necrotic tissue, extent to which the injured heart muscle has responded to treatment also can be determined. Cardiac muscle dysfunction noted on echocardiography. Management. Therapy is aimed at the protection of ischemic and injured heart tissue to preserve muscle function, reduce the infarct size, and prevent death. Innovative modalities provide early restoration of coronary blood flow, and use of pharmacologic agents improves oxygen supply and demand, reduces and or prevents dysarrhythmias and inhibits the progression of coronary artery disease. Oxygen therapy improves oxygenation to ischemic heart muscle. Pain control: endogenous catecholamine release during pain imposes an increased workload on the heart muscle, thus causing an increase in oxygen demand. Opiate analgesic therapy. Morphine is used to relieve pain to improve cardiac hemodynamics by reducing preload and afterload and to provide anxiety relief. Mifepristone is useful for pain management in those patients allergic to morphine or sensitive to respiratory depression. Vasodilator therapy. Nitroglycerin, sublingual, IV, or paste promotes venous low dose and arterial high dose relaxation as well as relaxation of coronary vessels and prevention of coronary spasm. Nitroglycerin low dose means venous. It promotes venous, and if it is high dose, arterial relaxation. Myocardial oxygen demand is reduced with subsequent pain relief. Persistent chest pain requires prompt action. IV nitroglycerin. Anxiolytic therapy. Benzodiazepines are used with analgesics when anxiety complicates chest pain and its relief. Pharmacologic therapy. Thrombolytic agents such as tissue plasminogen activate, streptokinase, and retaplase re-establish blood flow in coronary blood vessels by dissolving obstructing thrombus. No effect on the underlying stenosis that precipitated the thrombus to form. Administered IV or intracoronary. Second, second one, adjunctive therapy aimed at preventing fibrinogen from adhering to activated platelets may include administration of eptifibatide. Eptifibatide to prevent platelet activation. Aspirin. An anticoagulation therapy is useful as an adjunct to thrombolytic therapy, also used in situations of prolonged bed rest, pulmonary embolism, deep vein thrombosis, mural thrombi, cardiogenic shock, and patients with atrial fibrillation. Beta adrenergic blocking agents improve oxygen supply and demand, decrease sympathetic stimulation to the heart, promote blood flow in the small vessels of the heart, and have anti-dysrhythmic effects. Appears to lower mortality and decrease chance of reinfarction and sudden death post-MI. Anti-dysrhythmic therapy, lidocaine, decreases ventricular irritability which commonly occurs after MI. Calcium channel blockers improve the balance between oxygen supply and demand by decreasing heart rate, blood pressure, and dilating coronary vessels. Diltiazem has been shown to decrease the incidence of reinfarction in patients with non-Q-wave MIs and is currently the only calcium blocker proven to be beneficial. Percutaneous transluminal coronary angioplasty (PTCA). Mechanical opening of the coronary vessel can be performed during an evolving infarction. PTCA can be used as an adjunct to thrombolytic therapy. Surgical revascularization. Emergency coronary artery bypass surgery can be performed within 6 hours of evolving infarction. Definite treatment of the stenosis and less scar formation on the heart are the benefits of this therapy. Complications: rhythm disturbances, cardiac failure, infarct expansion, thinning and dilation of the necrotic zone, infarct extension, additional heart muscle necrosis occurring after 24 hours of acute infarction. Congestive heart failure with 20% to 35% left ventricular damage, cardiogenic shock, reinfarction, ischemic cardiomyopathy, cardiac rupture, papillary muscle rupture, ventricular mural thrombus, thromboemboli, ventricular aneurysm, cardiac tamponade, pericarditis 2 to 3 days after MI, psychiatric problems, depression, personality changes. So the main points to remember: there are two types of MI: transmural Q wave infarction, subendocardial non-transmural non-Q infarction. Chest pain is the main clinical manifestation. Diagnostic: ECG changes, elevation of serum enzymes, isoenzymes, elevated cardiotroponin, and elevated myoglobins. Management: oxygen therapy, pain control by morphine, and anxiolytic therapy, if the patient is with anxiety. Pharmacologic therapy, thrombolytic agents, streptokinase, tissue plasminogen activator, adjunctive therapy aimed at preventing fibrinogen from adhering to activated platelets, anticoagulation therapy, beta adrenergic blocking agents, antidysarrhythmic therapy, lidocaine, calcium channel blockers, diltiazem, and PTCA and surgical revascularization. Thank you.